Good afternoon, everybody. I am Dr. Jordan Awas. I'm a clinical associate professor at Xavier University of Louisiana. On behalf of Dr. Kathleen Kennedy, Dean of Xavier University of Louisiana's College of Pharmacy, the Center for Minority Health and Health Disparities Research and Education, and the entire Louisiana CAN and the HIV epidemic team at Xavier University of Louisiana, in collaboration with our partners at the Satcher Health Leadership Institute at Morehouse School of Medicine, we welcome you all and thank you for joining us for today's webinar, Leading the Charge, Advancing HIV Awareness and Education in Black Communities. This event is held in recognition of National Black HIV/AIDS Awareness Day, a day that calls us to action in the fight against HIV in Black communities. It is a stark reminder of the persistent health disparities that fuel this epidemic and the urgent need to expand education, prevention, and access to life saving care. It is also a day to honor the resilience of those impacted, celebrate the progress that we have made, and reinforce our unwavering commitment to ending HIV once and for all. Without further ado, I would like to introduce Dr. Lawrence Bryant, our moderator, who will take it from here, introduce himself, and welcome our esteemed panelists. Enjoy the discussion.
Hello, everybody. My name is Dr. Lawrence Bryant. I'm certainly glad to be here. This is a privilege to be able to be a part of this wonderful journey. And that's what I want you all to sort of go along with me, because this is a journey. But before we get started, I'd like you to just engage with me for a moment. And I'd like everyone that's within the sound of my voice, just for a moment, to close your eyes and reflect on and think about the data that I'm getting ready to share with you. Close your eyes. HIV in the US in 2022, there were 31,800 estimated new infections in 2022. Of these, 67% were among gay and bisexual men. 22% were among heterosexual persons. And 7% were among intravenous drug-using persons. Of these, the trends really move towards the Black gay community, where 1 in 2 Black gay men will get HIV within their lifetime if there's not significant interventions to help stop this epidemic. Let's look at Louisiana. In 2022, Louisiana ranked 4th in the nation for HIV/AIDS diagnosis rates, and the rates are per 100,000. In 2023, new data suggests that among gay persons, Black gay men, the data was 60%. And the most affected areas in in Louisiana is New Orleans and Baton Rouge. But let's look closer to home in Metro Atlanta. Metro Atlanta ranks 5th in the nation in terms of people living with HIV per 100,000. Counties most involved: number 1, Fulton County. Number 2, Stewart County. Number 3, DeKalb County. Number 4, Dougherty County. And number 5, Clayton County. This is what we are looking at. You can open your eyes now. And so the topic today is most appropriate for what we are dealing with. HBCUs leading the charge, advancing HIV awareness and education in Black communities. So, our wonderful panel of esteemed individuals will explore the critical role of Black colleges and universities and how they can play an important part in terms of equity for people living with HIV, as well as providing critical and valuable insights into the unique opportunities and challenges HBCUs face in addressing HIV on their campuses, and not only in their campuses, but also in their surrounding community. So at this point, I would like to introduce our very esteemed panel. And I tell you, I'm honored to be amongst these individuals. And I would ask each one to just give a brief synopsis of what they're doing, where they're from. And so first, let's bring on Dr. Benjamin Robinson. If you would, Dr. Robinson, come on down. Tell us a little bit about yourself.
Hey, thank you, Dr. Bryant. Hello, everyone. I am Earl Nuxius Benjamin Robinson. I am, just to tell you a little bit about me, I am a director at the Louisiana Cancer Research Center and also a senior director at the Louisiana Public Health Institute, overseeing the portfolio of community engagement. And I have a number of years as a public health practitioner working inside cancer and tobacco prevention and control, but I have a significant experience working as a public health practitioner in HIV and AIDS. And so HIV prevention and HIV care and services is dear and near to my heart, as I have many friends and family members and community members that are impacted by HIV. And so as a public health practitioner, HIV is one of those areas that a lot of my passion and a lot of my time is spent helping to support, empower communities. So I'm glad to be here today, lifting up this conversation and also speaking to what can HBCUs uplift or do more of to help support the African American communities, particularly as it relates to eliminating or greatly reducing HIV and AIDS in our communities. Thank you for having me today.
Thank you for being here, and we certainly welcome you. Next, come on down, Dr. Christopher Irwin, MD.
Greetings, everyone. Dr. Christopher Irvin. I am an assistant professor at Morehouse School of Medicine. I'm working in the departments of family medicine and PA studies. I have my other title is Director of Community-Based Initiatives within the Department of Family Medicine. So I do a lot of community-based work for Morehouse School of Medicine. One of my leading roles is the Director of Operations for the Morehouse School of Medicine Health Equity for All Lives Clinic. It is our student-led free clinic where we provide free health care to the metropolitan Atlanta area and do many of the health screenings in the community. I also have a long history of working within the HIV community of Atlanta, having served at the community level, worked on various regional and national organizations, and even served as the chair of the Georgia HIV Prevention and Care Council. I'm glad to be here to talk about many of the issues facing our community and how the HBCUs can help them. And greetings.
Again, thank you. We are just so fortunate to have you here. So we're glad about that. Next, come on down, Armani Moore. Come on down, Armani.
Hello, everyone. My name is Armani Moore. I am from Valdosta, Georgia. I am a first year physician assistant student at Morehouse School of Medicine. I am a proud alum of an HBCU, Florida A&M University. I am currently conducting systematic research on the prevalence of HIV in Black women while doing community engagement with organizations that are very vital to this cause. I am very excited to be here today and to be a part of this discussion with you all.
Thank you. And we again are so glad to have you as well. Now, lastly, Ms. Kennedy White, come on down.
Hi everyone, my name is Kennedy White and I'm a fourth year pharmacy student at Xavier University of Louisiana's College of Pharmacy. And I'm passionate about health advocacy and addressing disparities in underserved communities like my hometown of New Orleans. And in pharmacy school, I had the opportunity to take an elective titled HIV and AIDS in at risk communities, where I solidified my belief in the power of education and leadership to drive change. When Gilead Sciences partnered with Xavier to sponsor an HIV awareness campaign, I created an HIV awareness brochure, and we distributed these brochures during events and National HIV Awareness Days, including World AIDS Day, where I and some of my peers facilitated conversations and shared information about free HIV testing in New Orleans. So I'm really excited to be a part of the conversation today.
Again, thank you, our entire panel. And I'm ready. And I got my seatbelt buckled because, I want this discussion to be very, very intentional. Given the climate that we are experiencing now, given the potential uncertainty that we may experience, I really, really want this to be meaningful, insightful, and thoughtful. But more importantly, I want to be sure that we are given something tangible that we can take away with us in terms of recommendation from this very esteemed panel. So before we start, just a little bit about myself. I am privileged to be a policy core lead with the Satcher Health Leadership Institute. It's been a wonderful journey. I really feel like I'm just getting started. I've been doing HIV/AIDS work for almost 50 years.
Mm.
And I'm not tired yet. As a matter of fact, within the last couple of weeks, I'm just getting my second win. And so I'm ready. And so as we move forward, I'd like to ask Dr. Benjamin Robinson, if you would, because so much of what we're talking about is around health equity. And so let's just contextualize that so we all understand what we're talking about when we say health equity. So if you would, Dr. Benjamin Robinson, give us your insight around health equity and what that means as it relates to this particular topic.
Thank you, Dr. Bryant. So, as it relates to health equity, when I think of health equity, I think first, initially, I think that we are not all having the same experiences. We do not all have the same opportunities. We do not all speak the same languages. We don't all come from the same place. And so when I think about that, I also think about how those different things affect how we live life, how we experience life, and our health outcomes. So, at its core, for me, health equity is about one, realizing that people are having different experiences, but two, giving people what they need to achieve the best health outcomes, the best wellness, achieve that full potential of being their whole self. And so for me, health equity is about understanding that we are not all having the same experiences. We intersect in our society at different levels, and that intersection has to do with economics and other societal factors or other social determinants. But it's also about realizing that giving people what they need to be the healthiest, to be the most well that they can be.
Thank you very, very much. And certainly that provides insight in terms of when we move forward, how our conversation should be couched. So let's just start with our first question. And Dr. Benjamin Robinson, I'll also ask if you would answer our first question as well. And so the first question asks, how do cultural attitudes within the HBCU community impact discussions and education around HIV prevention? And while Dr. Robinson is talking on this, if anyone else would like to chime in afterwards, please feel free. But Dr. Benjamin Robinson, go ahead.
So, cultural attitudes can be a barrier to having discussions around HIV inside the HBCU environment. The HBCU environment is an environment that is very, very similar to the communities that we come from. The environment is very, very similar to the environments that our churches and faith institutions exist in. And so, given many of the issues are the elements that affect how we have conversation about sex, that affect how we have conversations about who people are having sex with, all of those factors have a part to play in whether or not people are gonna. Well, it has a part to play in people's attitudes, values, and beliefs regarding HIV. And so, I think overall, I think that when we are doing this work inside the HBCU environment, we have to take into consideration those factors. What are those cultural factors, those cultural attitudes that could get in the way and be barriers of us explaining to people that HIV is spread by having vaginal, anal, and oral sex. And human beings have either mouths, vaginas, or penises. And so not just some, but all of them have some have a part. And so being able to have those conversations very truthfully, being able to share how HIV is spread, and to the point that people don't think that only LGBTQ individuals or trans individuals are the only individuals that will acquire HIV, but building people's ability to understand that we are all at risk. And there are some of us that are disproportionately at risk due to social attitudes, due to cultural attitudes. So again, I think that it's imperative that inside HBCUs that we have those real conversations about what are those societal factors, those social norms that might be getting in the way of us really bringing a message to the young people and being able to support young people in being the most well and the most and being the healthiest that they can be, which is about health equity. So I think if we are able to have a conversation, open and honest conversations about cultural attitudes, and talk about it from the perspective of how might these attitudes be barriers to reduce what we see happening, that is health equity at work.
Thank you so very much. And was there anyone else? Dr.
Yes,
Irwin, would you like to chime in there?
yes, I would like to chime in. And we know that HBCUs have rich, extensive, and very vibrant histories. But we also have to add in, when we talk about culture, we have to remember we are not a monolith as well. That even within a very rich, rewarding, long tradition of our HBCUs, that there are subcultures within those cultures. First, there's urban versus rural. We have, our rural HBCUs that have a different culture than our urban. I'm a resident of Georgia, born and raised in Atlanta, ATL all the way. Um, Grew up in and around the AU Center with Morehouse, Spelman, Clark Atlanta University, and Morehouse School of Medicine, and been in Albany and familiar with Albany State, and have gone down to Fort Valley State and have good friends at Savannah State. We cannot compare the AU Center with Fort Valley and Albany State. Those are going to be two different cultures. Lived in DC. There'll be some who are going to say the real HU. I think our Hampton University graduates would beg to differ, but the DMV HBCU is not going to be the same as the Atlanta HBCU experience, not going to be the same as the Xavier and the NOLA experience. So even with our HBCUs, we have to recognize the cultures within those cultures, and even our diaspora. We talk about the Black American experience, and oftentimes that centers around the descendants of the formerly enslaved, but we have a growing presence of our Caribbean colleagues and our African colleagues. And so now we have to incorporate those cultures into the larger HBC culture as well.
Thank you very, very much. And so just to add just a little to that, the other thing that we can't forget is about the culture around heteronormativity and really setting a safe space for persons to be able to talk about who they are, addressing issues around homophobia as well within HBCUs. And I think those are some of the things that present barriers, but certainly conversations that we need to have. So thank you all for that. So our next question, and I'd like if you would, Armani, if you would answer this question for us. So what are some barriers that some students may face in assessing HIV/AIDS resources and services?
Yes, so there are many barriers that students may face in accessing HIV/AIDS resources and services. We need to first look at the social determinants of health and also personal choices that students are making, and for whatever those reasons may be. Some off the top of my head are like financial barriers, lack of access, educational barriers, or lack of awareness of the situations that they are in, or competing priorities or time constraints, even. When I think of financial barriers and lack of access, I think of having limited transportation in some cities. Like Dr. Urban discussed, more rural communities or underserved areas may not have the same access in bigger cities or such as like the Atlanta University Center. We can also think about restricted opening hours at health facilities. How can I go get tested when I'm in class all day if I don't have the availability to get to this facility during these hours? Some campuses offer free HIV testing, making it more accessible to students. But like I mentioned before, these might not be um, at the right times for students because of their schedules. At FAMU specifically, we had this big red bus that came on some Fridays, but this wasn't very frequently and it wasn't every Friday. So it's like, how can I go get tested if I'm in class? Or what if I have to work right after class? It's kind of pushed to the back burner. When I think of educational barriers or lack of awareness, again, it has already been being discussed, not knowing what is available to you or not knowing how HIV is transmitted, and how it can spread to different people. So that is a very important aspect to look at. And then another one I wanted to discuss is the competing priorities and time constraints. It may sound silly, but it's true. And a lot of times people are not focused on like going to get tested when they're in their late teen years or in their early adulthood, and they don't believe that this illness will impact them.
Thank you very, very much. And moving right on along. So this next question really asks how HBCUs incorporate HIV prevention education into their academic curriculum and student life program. And so, Dr. Irwin, you want to give that a shot?
Just coming off mute. Whew, this is a significant one, and one I am, always struggle with. I will start off with when I joined Morehouse School of Medicine. We had a committee called HIV Bench, Bedside, and Beyond. And the thought of that was, how do we particularly get our health professional students to understand that whatever their discipline is, wherever their academic pursuits are, when it comes to HIV/AIDS, there is a role, and that gets into the HIV prevention education part of the curriculum, and then we can move on to the student life. That how do we help our students, our health professional students, see that whether they want to be scientists, researchers, or clinicians, and in an age where even though we can treat HIV to the point it's a chronic disease, how do we still help them understand the life cycle, the biology, the biochemistry around it, where the research going, everything from preventive medications to vaccines, possibly. How can we make that a culturally competent and equitable process? And then once they start getting to their own clinical practice, how do they take those experiences and relate it to patients? But it's not just that. How do they become the agents of that change from a student life standpoint? In other words, what are they learning? How do we translate to that also being what they do? And that is a big challenge because I can say from a healthcare professional and a provider, I know one of the biggest challenges my colleagues ever had was talking about someone's about their relationship and sex lives. And if we are not teaching our students how to have that conversation amongst themselves within the student life programs, how do we expect them to have it with patients when can be a life or death decision. And so it's key that we do start looking at HIV/AIDS education, not only throughout all aspects of a curriculum, both didactic and clinical, but also what are we doing on campus within the student life programs, the learning communities, where those students can actually start incorporating those lessons within their lives. A great thing is working with Armani, and one of the programs I worked with in the past is, encouraging students to learn how to do HIV testing and counseling. Because once they learn how to do it, then they can start seeing how it reflects in their own lives and their lived experiences. And even, like I said, I run a student-led clinic, how they can incorporate those lessons into our student-led clinic. And so they're incorporating those lessons directly to the patients that they'll be caring for.
Okay, we're moving right on along. Thank you. And I had the privilege of actually teaching the HIV/AIDS course and developing the curriculum at Georgia State University from within an interdisciplinary program. So that's another option and opportunity to be able to interject HIV/AIDS in interdisciplinary kinds of programs. And so within that, there were students that were from public health, social work, nursing, respiratory therapy. And so that also represents an opportunity to sort of interject within some of those curriculums, HIV and AIDS as well. And so thank you for that. Okay, so now it's moving on to the next question. So the next question asks, what role do peer education programs play in HIV prevention on HBCU campuses? And this is two-part. And how might they be implemented? So I'll read that again. How do peer education programs play in, or what role do peer education programs play in HIV prevention on HBCU campuses, and how might they be implemented? And so I'd like to reach out to Armani for that as well.
Okay, so peer education programs play an important role on HBCU campuses in the HIV prevention. I would say hearing from those and learning from those that share your same experiences, look like you or are in the same community as you, goes a long way when it comes to HIV prevention and sexual health, and reducing these risky behaviors and just fostering an open dialogue for people to engage with each other and to learn from each other. These type of programs are effective because they utilize students who understand like the different social, cultural, and different group dynamics that shape people's behaviors and attitudes on these campuses. So this can be done through like peer-led workshops and events, or even making a part of this program mandatory for students at this school, having staggering dates and using student organizations such as sorority and fraternities to spearhead these events maybe, and also collaborating with health services so that we can get the resources that are needed to be able to support these peer education programs.
Fantastic. So, Kenny, we want to get your input on this topic as well. I know that you have just been just as urging to go, so we want to hear from you.
Yes, so I think peer-to-peer education is really important because it creates this safe space where students can voice education about HIV and shed light to other students. And so I mentioned how for the Gilead Sciences and Xavier partnership, I had the opportunity to create a brochure, and me and some students did canvassing. So we were on Xavier's campus, passing out the brochures and talking to students. And so that I would say is an example of peer-to-peer education. We were able to talk and educate and just listen to some of their thoughts on HIV. And we were able to fill in some of the gaps that they had about HIV education. Overall, I think that peers play an important role when it comes to education, and education and testing. I also think that resident assistants, so RAs on campus, should also be included in the conversation because they have the most access, especially to freshmen. And so when freshmen are coming on campus, they're new, they don't know about where the resources are for that college or university. And so I think resident assistants should also be included in the peer-to-peer education.
Fantastic. I knew you were just waiting there, and that definitely was insightful. Okay, so in our next question, how can HBCUs partner with local health organizations to enhance HIV prevention efforts on campus and surrounding communities? And so, Dr. Erwin, would like to hear from you, but also would like to hear from our students as well, Armani and Kendi. So first we'll go with Dr. Erwin.
Great question, because it's critical for HBCUs to be involved with the communities, period. Yet we cannot have this closed door approach or a gatekeeping approach if we're going to be part of the community. That oftentimes the community knows better than we do. Yes, we have multiple degrees, we have titles, we have accolades, but when it comes to community-based engagement, we have to humble ourselves and listen to the community, find out what they need, what they want to know, and how they can educate us, as opposed to we educating them. I was just responding to a question within the comments section about, the role of people living with HIV. And I was saying that it has to be critical that any programming, activity, curriculum that's developed and run around HIV and AIDS on our HBCUs, if it doesn't involve persons living with HIV, and a phrase I like, MEPA, meaningful involvement of people living with HIV/AIDS, is it truly engaging the community that's going to be impacted? And so, yes, there has to be true partnerships that is more the HBCU listening than telling our community partners what to do if there's going to be a change in the impact that we can have around HIV/AIDS within not just the Black community, but the larger community as a whole.
Absolutely. Thank you. Kendi, go ahead.
I would say that partnerships with local health organizations can increase access to resources. And I've been thinking about this, like a creative way that we can do this would be to bring sexual health vending machines stocked with like at-home testing kits, condoms, and other essentials in resident halls or even student centers. I think that could increase access and resources for students that they can have access to this anytime that they may need.
Okay, Armani.
So I think that HBCUs can partner with local health organizations, maybe by bringing to the forefront things that we might not be getting information about just because of this new censorship that's going on. You're not getting information from the CDC or the FDA or other health organizations. So maybe HBCUs can partner with locals to make sure students are still getting valuable, relevant, and accurate information, even if it means releasing these announcements themselves on like media like TikTok or YouTube, because I know that's very popular amongst the student population.
Okay, thank you very much. So moving right on along, and one of the things that when I was actually teaching the HIV/AIDS course at Georgia State, one of the most impactful things was guest lecturers. And so there, people came from community-based organizations, but that established a relationship. And these same individuals would come semester after semester. Actually, we developed a relationship. And here it is, students then sort of engaged them, for example, internships. And so that relationship actually was reciprocal. And I tell you, people like like Dazon Dixon from Sister Love came every single semester, and I must say, she lit the house up every time she came. And so just those kinds of things I think are very, very important just in terms of establishing relationships. So next, what role can HBCU alumni play in supporting HIV prevention initiatives and outreach efforts? And so I'd like to again hear from our students. Ken, do you want to go ahead and tackle that one?
Yes, I can. I would say that like alumni can get involved in several different ways, but one could be even like a scholarship fund for students where they can create like an innovative way to share HIV awareness. So a project, so students can be creative, write an essay, design a flyer, a brochure, or maybe even make a TikTok that educates their peers, and just allowing the alumni to be involved as well as students as well.
Absolutely. Thank you. Armani.
Hello. I think that HBCU alumni can play a role in supporting HIV prevention on campus, mostly, like Kennedy said, from donations and making sure that there are safe spaces on campus or building campus health infrastructure, making sure that, like I said, we had this big red bus that came to do HIV testing infrequently, making sure that it's there more frequently through their donations, and even mentorship. It's There are many people living with HIV who would benefit from having someone to mentor them and to motivate them through life's challenges.
Fantastic. Any one of our other esteemed panelists want to add to that?
I want to go back to something that you stated earlier about bringing, I think it was a question before this one, where you talked about reciprocity and working with community-based organizations to bring guest lectures in. I think that is, Dr. Bryant, I think that is one of the things that I think needs to be happening more and more on HBCU campuses, where community-based organizations that are working in HIV and other health issues are invited to the university to share information, to bring resources. I think that is indeed one of the ways that we can help to reduce some of those cultural attitudes that are barriers that we talked about as with the first question. But I think you brought up a very good point in just reciprocity and working with community-based organizations that have real, authentic relationship with community and the subject matter of HIV, to be speakers, to be resources to those students who might be most at risk for HIV, while at the same time helping to serve their community and work with the university. So I just wanted to lift that up, and I like that idea.
Absolutely. And one thing I want to say about that particular course, because it really was a very engaging and dynamic course. And one of the things that I did was to have them to do individual and group assignments as their final project. And one of the things that I asked them to do is to engage in some kind of activity that exemplified elements of HIV/AIDS. So, for example, some of them did plays, and they were very creative. They were very excited. Some of them just did some kind of theater kind of representation, but they were very, very creative. And unfortunately, I don't think that course has been taught since I left there, and that was maybe 7 or 8 years ago. But it certainly was an exciting experience. Okay.
Let me just say one thing. I think those are the kind of things that probably need to be happening more of at the university level. Just doing those kind of psychosocial exercises, so that students become the discussions around HIV become very, very normal. Versus, when people think about HIV discussions, they think if I'm having the discussions, something is wrong with me. But I mean, those kind of things help to normalize the HIV discussion, which I think is very, very important inside the African American community, and in particular inside HBCU environments.
Absolutely. One of the other things that was important at the very beginning of the semester, we had a list of guidelines for what will be allowed during the course and what will not be allowed. For example, disclosure. If persons would disclose personal information about themselves, we absolutely made them sign a contract to make sure that what was said in the classroom stayed in the classroom. So that was very, very important. And for the most part, everybody adhered to that. Okay, so we've got 5 or 10 more minutes. And so with that time, I want to really engage you all with the last two questions. The next one, and I want to just spend a little time on stigma because that's one of the areas I think that still needs to be dismantled. It still needs to be addressed. Although when we look back at the 80s and the early 90s, stigma was much, much more pervasive in a lot of our communities. It still is. And so I want to ask each one of you. We'll start with Kennedy and go on to Armani, then Dr. Benjamin Johnson, and then Dr. Irvin. But how does stigma surrounding HIV affect students at the HBCUs? Excuse me. And what can be done to combat stigma? Kendi, come on.
Yes, I would say that stigma is one of those internal barriers. And testing can be scary, but I think it's also scarier to not know one's status. And so to help combat stigma of testing, or even seeking knowledge about HIV, I would say that it's important to think of HIV as any other health condition, whether that's like diabetes or high blood pressure. It's not taboo to check your blood pressure or your blood sugar. So why are we making HIV testing so taboo? We should normalize it.
Thank you. Thank you. Absolutely right. Oh, okay. Go ahead, Amani.
I think another part of that is the misinformation and the myths that go around concerning HIV. Students may believe that, oh, I can't get HIV because I'm not promiscuous, or it's only a concern for certain groups of people and it doesn't pertain to them. However, I do think sexual health education classes can be incorporated into a curriculum, and not just for students who are in health related fields, but even when it goes to like people who are studying law or pre-law, maybe like policy surrounding HIV or anything that can get students engaged in the classroom in a mandatory fashion that can help with HIV prevention.
Fantastic. Okay, moving right along. Dr. Benjamin Robinson.
I want to say first that I really enjoyed what Kennedy and Armani said. I think those are some very good examples of things that can help to reduce stigma, to normalize HIV discussion, and to normalize those things that can help to reduce HIV prevalence. I think, in relationship to your question, stigma keeps people not in care. Stigma, still to this day, we have young men and women who are dying from HIV. I think it was Kennedy, no, I think it was Armani who said it's important for us to have this normalization. Like you go get a high blood pressure test, you can go get an HIV test. HIV is a disease that is manageable. Let me repeat that. It is a manageable disease. However, for many inside the African American community, in particular LGBTQ individuals, they are disproportionately still dying from HIV. They are still disproportionately showing up with late stage HIV/AIDS. And so stigma plays a huge role in that. And so I think there's this need for us to continue to have conversations around them. I think that we need to lean into HBCUs as best we can, understand what might be some of the barriers that exist inside the environments inside HBCUs so that we can overcome those barriers, so that we can utilize those HBCU environments to get students what they need so that they can achieve the best health outcomes, whether they are HIV negative or they're HIV positive. And so stigma continues to play a huge role in the prevalence of HIV in the African American community, and stigma still contributes to people not being involved in care and still people dying. Every day, we still hear about individuals, young people, young men and women, in particular, young men who are dead at the age of 25 or 27 or 30, and in some cases even much younger than that. And so stigma is a huge thing. And so we have a part to play. And I think HBCUs, I'm liking what I'm seeing with this collaboration that's happening between Morehouse and Xavier University. I think more of these discussions need to be happening. But I think also attention needs to be paid to what are those cultural attitudes that might be getting in the way of us really moving the needle when it comes to HIV. Because as you said it at the beginning, African American young LGBTQ individuals represent 60 something percent of new infections in 2022 and also in 2023. So this is something that we're still dealing with. And so our white counterparts are able to manage their conditions better than we are able to at the present moment. And that's due to a number of social factors. But I think we have to assess inside the inside the HBCU environment, what are those cultural attitudes that might be getting in the way of us doing what we really need to be doing to help bring the prevalence of HIV down.
Absolutely, absolutely. Okay, Dr. Irwin, take us home with this question.
Ooh, I don't know if I can. I mean, Dr. Benjamin Robinson pretty much said it all, but I'll try to add to it. It really goes back to the very first question. What are our cultural attitudes within our HBCU communities, and how do we use those cultural attitudes to other people? And that's really, the gist of the stigma. Why have, of all the ways we call ourselves advancing within the community, why do we still other our communities through HIV? For when it comes to patriarchy and the definition of masculinity, we other our young gay, our young same gender loving men, and so we're stigmatizing them. On one hand, we are celebrating Meg Thee Stallion, Cardi B, Sexy Red, and Glorilla, and then flip it and other our Black women around their sexuality and their sexual freedom and their sex positivity. We do it through religious beliefs, through patriarchy, through socioeconomic status, and we do know that one major component to the risk factor for HIV infection is actually socioeconomic status more than anything else. And so if we're othering people around their mental health, their socioeconomic status, their sexuality, their religious beliefs, and then slap the scarlet letter H of HIV on top of that, how do we expect people to want to get tested? How do we want them to get care? How do we want them to stay in care when we are going around doing TikToks talking about we listen and don't judge, and with rank hypocrisy, judge the very people that are needing love?
Absolutely.
Because the key to preventing HIV is helping people see them as whole people, that their sexuality, their physical health, their mental health, their relationship status all becomes who they are. And as Dr. Benjamin Robinson said, HIV is treatable, but if we use that as a weapon against them, how can we treat it?
Absolutely. Thank you. And I certainly think the one thing that I just want to add to that, and one of the things, and this was mentioned earlier about telling our stories. That is one way that we can put a human face to the persons with the disease of HIV. And in terms of myself, I never, ever thought that I could stand before people that I don't know and share my journey of living with HIV for almost 30 years and being in long-term recovery from substances for 33 years. But if there's anything that I can do to be a catalyst for change and I can use myself, I'm willing to do that. Plus, I'm going on 72 years old and I really don't give a damn what people think. And so we've got maybe 5 more minutes to answer this last question. Evan and whoever else is behind the scenes could maybe write down some of these recommendations. But our last question, and we probably need to be brief because we want to make sure that we have audience participation and audience questions afterwards. But I think this is important. So, to each panel member, what is your vision for the future of HIV prevention among HBCU students? And what steps or recommendations can you take in order to achieve this? Let's go ahead with Dr. Benjamin.
What I would like to see in the future is same gender loving men and women at HBCU campuses feeling comfortable to be their authentic self in those environments. Because I think that is one of the key things that will help not only with wellness overall, but that is something that will also help with HIV prevention and control. So for me, it is about, and what I would like to see in the future is that sexual gender minorities, particularly LGBTQ trans individuals, being feeling welcome inside their organizations and institutions that are HBCUs. And I think one of the ways that we do this is by, to the point that you made earlier, working with community-based organizations that are not only working in HIV, but that are also working with building the self-esteem of sexual gender minorities. So working with pride organizations, working with community-based organizations that are just simply dealing with lesbian issues or gay black men issues, bringing them into the fold because these individuals are at your institutions. They are attending these institutions. And so I think because I think when people are able to see themselves, they will more likely be able to be themselves in a more holistic and healthy way. So that's my 2 cents.
Thank you, thank you, thank you. It's worth a lot more than that. Okay, Dr. Irwin.
And I'm going to extend Dr. Benjamin Robinson, statement to say that HIV is more than sex. It's about relationships, and be it heterosexual or cis het relationships, same gender loving relationships. How do we start looking at sexual health as part of the whole person, their entire being, their entity? Because then that allows us to incorporate the mental health, the interpersonal relationships, the ability of all partners to have the discussion around getting tested, being healthy, being in this relationship together, and what that's entail. Because too often, particularly having worked with a lot of Black women, they're reduced to condoms and no condoms. Not what does it mean for a Black woman to be in a relationship, to have that conversation with a partner, both in the short term and the long term. Do we use condoms? Do I be on PrEP? What does it mean for me having a family versus condoms and no condoms? And this ties into many of the other issues we see around interpersonal relationships, regardless of gender status, because it goes to the same gender couples as well, or partnerships. What does it mean for us to be on PrEP? What does it mean for us to engage in, sexual health? Who's going to go to the doctor? Who's not going to go to the doctor? And it does take, as Dr. Benjamin Robbins said, bring in various organizations. I've seen gender organizations, our intimate partner violence organizations, our mental health organizations coming into the HBCUs so we can start seeing what does it mean to be a healthy person of color, and what does it mean to be a healthy person of color in love with another healthy person of color, and how do we both keep ourselves healthy, and then extending that so we can now start teaching particularly health professional students when they become providers, when they become social workers, when they run health departments, to instill that same mindset so we can also start installing that vision and purpose into our community and our patients, so then we can start having the impact that we need. Because we've been having this discussion for 30 years. And I can say you, Dr. Bryant, can definitely say for you, Dr. Benjamin Robinson, the conversation hasn't changed. And there's a reason why, because we still are afraid to have the true conversations of what does it mean to be a healthy Black person in this country that wants to be not just HIV negative, STI negative, not to have diabetes, not to have blood pressure, recognize we have a mental health issue, not to be on substance uses, because they all are incorporated into who we are and why we're still having this discussion.
Absolutely. Thank you so much. And so quickly, we've got just a couple more minutes. And if Kendi and Armani, you would give us your take on the recommendations. Kennedy, go ahead.
Mhm. I would say also extending those partnerships to churches so that we can start having the conversation there, and normalizing it and extending access, because I think when you don't have access, then people feel as though they don't know what to do. And then I would say increasing those electives that help students understand what HIV is and for them to be advocates on their campus. I had the opportunity to take an HIV elective as a pharmacy student, but I think that undergraduate students would also benefit from this opportunity as well.
Thank you. Thank you. Okay. Go ahead, Armani.
I envision a campus environment where HIV education is integrated into the curriculum, where comprehensive sexual health services are readily available to students, and where students are provided with safe spaces and accurate information to support them without the fear of a judgment. And this can be done through advocacy, through research, community engagement, training future public health leaders, and training them appropriately, also establishing comprehensive campus health services and utilizing that alumni network. And we, of course, have a long way to go, but like Dr. Irvin said, the conversation has not changed, but some of these recommendations can make all of the difference in the long run.
Absolutely. I want to thank our esteemed panel. And I tell you, my cup is running over and full. This has been not just me facilitating this, but me also learning. And the engagement has been phenomenal. Now we want to open it up to our audience. And we've got about 10 more minutes to be able to do that. So I see we have a question. I don't remember anything on U equals U. Do you think U equal U reduces stigma in your experience? What about DoxyPEP in this conversation of increasing equity for people living with HIV? Who wants to take on that?
I think Dr. Griffin brings up a good question. I think that comes from Daniel Drifton. Excuse me, I said Griffin, but I mean Drifton. I think he brings up a good point. We didn't discuss U equals U, but I think that that is something that should be a part of the landscape on HBCU campus, because many students are not aware of U equals U. They are not aware that a person who is living with HIV and that is undetectable and taking their medications 95 to 99% of the time will not be able to transmit HIV to someone else or pass HIV to someone else. And so we need to be having conversations about that. I do think that that will help to also reduce the stigma, the experience of stigma. But the issue is, well, there is no, well, and the issue is we're not having enough conversations about it. Our white counterparts are benefiting from the campaigns of U equals U. They are benefiting from these efforts, and yet we are still not. When many of us African Americans are going into our provider's office, information is not being shared with us in this way, and so we need to continue to share information and also expect our providers to share this information with us. So I think U equals U, Doxy Prep are things that can definitely be done to as it relates to equity, to make certain that people are aware of the resources and also aware of what the new science is indicating around people who are in care not being able and taking their medications 100% of the time, not transmitting HIV to other individuals.
Thank
And I would
you.
take it a step further, definitely would help with the stigma, but I would hope it will also motivate many of our young HBCU scientists to know that, you know, this we can achieve an undetectable status. We can achieve a status where it can't be transmitted, and this may spur to do more as a way to address the stigma, knowing that medications are out there to reduce transmission. Um, Medications out there to reduce STI infections. Uh, that definitely will help the stigma, but also maybe spur more research by us for us as
Mhm.
well.
Great.
There was a time there was a fashion line called FUBU, for us by us. In addition, it will hope to expand the conversation as well.
Absolutely.
That if you equals you, um, that means we can have a relationship. We can have open discussion on how this is going to work for us.
Yeah.
And so I think it will help with the stigma. It may spur some research, and it may advance the discussion across the board.
Absolutely. And before we go to the next question, the other thing is, um, and I think both students illuminated this, the importance of testing. You got to be tested in order to determine if, in fact, you go on antiretroviral therapy and become undetectable. That's the word that we use to mean that the virus is so low in your system that it's undetectable by our clinical apparatus. And so that's very, very important. Okay, how can we start our conversation with churches who have health ministries but don't address HIV topics? Who would like that? And I think, Armani, you talked about that?
I think we all touched on it a little bit. I think that it could be pretty hard to do this because a lot of these religious beliefs are deep rooted. However, I think involving a healthcare professional and bringing experts in to talk with churches and their members about HIV and its prevention can really do good in this situation, and host informational sessions or events and workshops for church members, basically to hear, to learn about HIV, to learn how it affects people and everything. And I think that it could be hard to do, but it is doable.
Absolutely. And one point there, the organization, the Balm in Gilead, is an organization that really provides guidelines for church ministries, and really setting out how they should be run, and how they can benefit the congregation as well. And so I certainly think that that is a resource that's important.
Brett,
Okay.
I also want to add in that conversation is that we also have to be honest too, and I think Armani spoke to this about it that being difficult. I'm sorry, Imani, for forgetting your name for a moment. That being difficult, you have to assess sometimes that you may not be able to go to some churches because they may not be ready to have these conversations, or if they are ready to have these conversations, they may not be ready or have the capacity to have these conversations in a way that further harms populations. And so I think that has to be a part of the conversation. I think that it's wonderful and great if you're able to find faith-based institutions who are ready and have the capacity to share information in a way that it allows people to, one, be who they are, but also receive the message. But if they're not ready to do that, I think the assessment should tell you, hey, this organization, this faith-based organization may not be ready to do this work. And so maybe we provide them or give them access to BUM and the Gilead organization that I know has funding to do that kind of support. But we really have to be honest sometimes that some of these faith-based institutions are not ready to do this work.
Absolutely. Thank you. Another question. This is kind of long, so bear with me. You all mentioned prevention a few times, but I also wonder what can be done to make HIV routine in primary care and other aspects of medicine. In Atlanta, we have more than 1,900 not routinely in HIV care, and they are being missed by the different medical circles like ER and primary care. And quickly, because we only have just a little time left, Dr. Irwin, you want to answer that one?
I
I
will
know.
try to answer this one quickly. Quickly is going to be the challenge here. It goes back to the fact that we like to say that there's healthcare access in the metropolitan Atlanta region. There isn't. I like to rephrase it whether or not we have health actuality. In other words, if does a health facility actually have the capacity to care for the people it's supposed to care for? Do we have health actuality? And I can say running a free clinic, we don't. Too often, those needing the most care have the least means to receive that care, even in the city of Atlanta. Uh, Granted, there are what they call federally qualified health centers. Yes, they're supposed to be doing routine HIV testing and care, but they can still put up barriers for those to receive that care. We won't even talk about private medical facilities, um, which don't always even provide care to the people who have the insurance at the level that they need. And so when you start adding the chronic diseases such as HIV, such as diabetes, such as hypertension, the more economically stressed you are, the more socioeconomically disadvantaged you are, the less likely you're going to receive care. And so we have to do two things. One, improve the ability of anyone in the city to get care. And then as we improve the ability of people to get care, to make sure that our providers, be it MPs, PAs, MDs, DOs, and all the rest, recognize that HIV is a primary care issue and that as part of any primary care treatment, HIV should be a component of that.
Okay, thank you. Got time for maybe one more question. So, if there are no more questions, again, I want to say thank you to the panel. And before we leave, um, I just want to say that this has just been a phenomenal experience, and I know that we weren't able to discuss everything that we probably wanted to discuss. But overall, I think this has just been rejuvenating given the circumstances that we're dealing with. And so, just some resources in terms of here in Atlanta. And so, we've got at Morehouse School of Medicine just a plethora of services around HIV. AIDS Education Training Center right here at Morehouse. We provide technical assistance as well as trainings around HIV and AIDS. The African American Center of Excellence does a wonderful job in terms of providing training around HIV and AIDS and other topics, including substance use disorders. And of course, the Satcher Health Leadership Institute just provides just so much, particularly around health equity. And I'm just so glad that we stand very stoic in that we will continue to commit to health equity and commit to making sure that all members of our population are treated fairly. And of course, one of my favorite departments, the Prevention Research Center right there at Morehouse. I actually used to work with them. And so they provide a lot of education around HIV and AIDS. And finally, Chandra Edwards is from the Office of Academic Program out of Columbus, which is one of our role partner. And she does a lot around harm reduction as well as opioid awareness. So I'd like to just leave you with a couple of quotes because, as you can see, we're standing on the shoulders of powerful ancestors, and we should never, ever forget this. No matter how much they try and dismantle our history, we will continue to stand strong. And so, too, that I like to hearken in terms of lessons learned. One of them is Martin Luther King, and he said, of all forms of inequity, injustice in healthcare is the most shocking and most inhumane. And we are experiencing that today. So certainly this is relevant for what's going on today. And lastly, one of my favorite, Bayard Rustin, who almost single-handedly orchestrated or helped Martin Luther King orchestrate the March on Washington. But he goes on to say, we need in every community a group of angelic troublemakers. And so what that means is that now is not the time to go somewhere and sit down. Now is the time to buckle up. Now is the time to continue the good fight. And so I want to encourage each and everybody. I want to inspire each and everybody to your own greatness and to understand that in the end, we will prevail. In the end, we will be victorious no matter what people try and bring against us. Because if we can go through what we've gone through already as African American people, we can go through anything. So thank you. And I'd like to turn it back over to Evan, are we turning it back over to you?
Yes, sir.
There
Thank
we
you.
go.
Thank you so much, Dr. Bryant. Thank you so much, Dr. Irvin, Dr. Benjamin Robinson, and really thank you to our future generation of leaders in Kennedy White and Armani Moore. And thank you to all of those who are still with us on this very important webinar, on this very important topic. Thank you for devoting your time to joining in and listening to this very insightful conversation with, helping to create a space for honest conversation, for a safe space to, recognize we're in this fight together, especially those inspiring words from Dr. Bryant. As a reminder, please ensure that you complete the webinar evaluation today. We would love to get further information from you in terms of your thoughts on our discussion today, what went well, what could be improved, what other things you want to learn about, the work that the answers that you will provide will help to inform our work greatly. And so we are looking forward to that. We will be circulating more information about our next upcoming webinars, where future discussions will also be led by the great Dr. Bryant. So thank you to all again for your time, and have a good rest of your Tuesday.